This session we are going to see endometriosis. Endometriosis is occurrence of ectopic endometrial glands or tissue outside the uterine cavity. Endometrium ideal place is uterine cavity, and we know that under the hormonal influence, estrogen acts on the endometrium, it proliferates. When progesterone comes in, there is secretory change. Once there is withdrawal of both the hormones at the end of the menstrual cycle, there is shedding of the endometrium, which is visibly seen in the form of menstruation. So every month from puberty till menopause, these are the changes taking place in the endometrial glands. Now, if these endometrial glands are ectopically placed outside the endometrial cavity, what will happen? Under the influence of these hormones in the body, they will also have these changes like proliferation, then secretory, and then shedding off. So that will cause problems because this menstruation will take place outside the endometrial cavity. What is the incidence? It's almost around 20 to 40%, 10% in normal population, and in infertile patient the incidence is much more, that is 20 to 40%. Age group 30 to 40, the reproductive age group. Again seen in high socioeconomic status, nulliparous patient, more seen. Maybe infertility and endometriosis, they go hand in hand. First degree relatives, again the chances are 7 times higher if first degree relative has endometriosis. It's a estrogen dependent condition. DS exposure in utero increases the risk of having endometriosis later in life. There are many theories put forth that why this endometrium gets implanted ectopically. Common or the first theory is Sampson's implantation theory. What Sampson thought is during menstruation, this endometrial glands, if they go retrograde, there is retrograde flow, means from the fallopian tubes they go and they land up in the peritoneal cavity, and these endometrial glands get implanted over there and they start growing, and under the hormonal influence they menstruate. That is Sampson's implantation theory. Coelomic metaplasia theory has been put forth by Mayer and Ivanov. What they thought is the peritoneal mesothelium or the epithelium, it undergoes metaplasia and it changes to endometrial epithelium from its original, that is embryonic mesothelium. So the metaplasia takes place. Metaplasia is changing over of one epithelium to other epithelium. Metastatic theory put forth by Herbal. He explained why this endometriosis can take place to distant organs like umbilicus or episiotomy scar. So he said that the endometrial tissue get metastasized either by vascular pathway or through lymphatics and gets dislodged to these distant places, and there the endometrium starts growing. So it's a metastatic theory by Herbal. Histogenesis by induction. This theory was put forth by Merrill. He suggested that maybe there is some biologically active factor that acts on the endometrium and causes change from one to another. So this endogenous biochemical factor can induce undifferentiated peritoneal cells to develop into endometrial cells, and thus leading to formation of endometriosis. And maybe some hormonal influences can lead to endometriosis. Now, what are the sites? You think of an organ and you will find that endometriosis can reach there. But the most common site is ovaries. 30 to 40% patient has ovarian affection and there is formation of cyst. The next most common site, if your MCQ has no ovaries as an option, the next site you should think is pouch of Douglas. Because it's most dependent in the peritoneal cavity, anything can come and get dislodged or get placed over there. So ovaries, first common, second common, pouch of Douglas. We have covered 3 MCQs here. Uterosacral ligament, round ligaments, rectovaginal septum, fallopian tubes, and anything in the abdominal cavity. Intestines, bladder, vagina, vulva, which is outside, but abdominal wall, Again, go and high up and think lungs, pleura, brain, arms, anything can be site of endometriosis. Even scars are not spared by endometriosis. Hysterectomy scar, myomectomy scar on the uterus, episiotomy scar, classical cesarean section scar, ventrofixation, fallopian tube if there are any operations, operations for pelvic endometriosis, all these scars can be places for endometriosis. The pathology is there can be just red petechial patches, the implanted endometrium, or there can be powder burn lesions, or the lesions can also be explained as gunshot, because if you have seen that once there is gunshot, there is this carbon spreading which takes place near that gun area. So the powder burn appearance or gunshot appearance is second most common type of lesion found in endometriosis. First common is just red petechial patches. In severe types, there can be bilateral chocolate cyst formation or endometrioma. Endometrioma is collection of tarry dark brown fluid. Please remember the color. It is tarry dark brown fluid because of hemosiderin pigmentation. The fluid gets absorbed and what remains is hemosiderin, and that gives appearance of chocolate color fluid, tarry dark brown liquid. MCQ has been asked which describes the color also, that what color the cyst would have, whether it is yellow, clear or dark in color or tarry dark in color. The peritoneal cavity fluid is yellow brown in color. It is never clear. So these are different lesions of endometriotic presentation. What are the risk factors? Single nulliparous patient, early menarche, non-oral contraceptive use, non-smoker, shorter cycle or longer duration of flow, dysplastic nevus syndrome, melanoma. These are the risk factors for endometriosis. Symptoms. Usually the patient presents with either pain or with infertility. These are two common symptoms of endometriosis. Pain in the form of severe dysmenorrhea. This dysmenorrhea is classically explained as it is secondary, usually starts after 30 and it goes on progressing. It gradually goes on increasing. Chronic pelvic pain. This pain is dependent on the depth of the invasion. The endometriotic tissue, more the depth, more the pain. So pain in the form of either dysmenorrhea or chronic pelvic pain irrespective of the cycles. Dyspareunia is the third form of the pain. So pain is major complaint in case of endometriosis and it's quite severe and disabling pain. Patient wants relief from this pain as the main complaint. Infertility and menstrual irregularities. It disturbs the whole peritoneal environment. It causes tubal block, it changes tubal environment, it leads to peritoneal factors, it causes adhesions in the peritoneal cavity. So because of all these lesions, infertility is very commonly seen in association with endometriosis. It can also lead to menstrual irregularities in the form of menorrhagia or polymenorrhea. What are the investigations? The gold standard is diagnostic laparoscopy. Once you think endometriosis, immediately think of putting a scope inside and looking at the lesions. Diagnostic, because you're seeing the lesions. We have described them, petechial or powder burn, gunshot, cyst formation. So you put a scope and look at these lesions and diagnose endometriosis. And at the same sitting, you can even be therapeutic and do the treatment of these lesions. The lesions can be typical or can be atypical. We have to have histopathological confirmation to say that this is endometriosis. So we can just take biopsies from the lesions and send it for the histopathological examination. CA125 raised but not very specific. Ultrasound, yes, it tells us about the cyst formation. MRI can also be used. But the investigation of choice in endometriosis is always diagnostic laparoscopy. American Fertility Society has classified the endometriotic lesions into minimal, mild, moderate and severe variety. Whenever there is just small patches are seen without any adhesion formation, they are minimal, and severe variety is big cyst formation, endometrioma with lots of adhesion, that falls in severe variety. And in between you can imagine the spectrum. How to manage endometriosis? Medical management and surgical management. In medical management, we have to manage pain first and then the lesions. Pain can be managed with the help of NSAIDs. There is one more slide where I will tell you what things can be done for pain. For the lesion management, we can have drugs like progesterone, GnRH analogs, antiprogestogen like mifepristone. OC pills is quite commonly used in practice as a treatment for endometriosis. Gestrinone, letrozole and danazole can also be used. The limitations are they shrink some type of endometriosis which are estrogen sensitive. But there is again reappearance. So shrinkage is not complete, usually leaves the micro disease. Results for infertility treatment not really very convincing, and medical management cannot really deal with adhesions which are formed inside the peritoneal cavity. Surgical management, either conservative surgeries in the form of fulguration of the endometrial deposits, or we can go for cystectomy. If the cyst is small, less than 3 cm, we can just put a scope and aspirate the fluid inside it. But if the cyst is larger in size, more than 3 cm, then we can go for cystectomy. These are all conservative surgeries. The adhesions formed, adhesiolysis can be done through a laparoscope. For the pain, there can be laparoscopic nerve ablation. If the patient has completed family and she doesn't want to continue, then the best treatment would be total abdominal hysterectomy with bilateral salpingo-oophorectomy, in which we try to remove the endometriomas as well as the uterus and fallopian tubes, which are the site of the endometriosis, are also removed. Pregnancy has variable effects on endometriosis, persistence, regression or progression. Laparoscopic ablation of visible endometriosis in infertile women is associated with significantly increased fertility rates. So if the patient is having infertility, then laparoscopic fulguration of the lesions and then immediately going for fertility procedure are very important. IVF also plays a very important role in the treatment of endometriotic patients. For pain, NSAIDs all significantly they have much effect. Naproxen, mefenamic acid. The other thing which we can do is herbal remedies. Even sometimes the patient may require antidepressant, OC pills. Many psychophysical treatments in the form of acupuncture, massages, relaxation, these are also used. Exercises, anti-estrogenic drugs, and sometimes nerve ablation or open surgery is required for the management of the pain. The pain is very severe and patient usually needs relief somehow from this endometriotic pain. So that finishes the topic of endometriosis. Thank you.